Hi, my name's Nourah. Thank you very much for this opportunity. I have nothing to disclose. Postoperative ileus is common after gastrointestinal surgery, and it's been associated with significant morbidity and costs. However, one of the issues is that it's poorly defined in literature, therefore giving it a very wide incidence rate from 3 to 32%. So this lack of a consensus definition in postoperative ileus makes developing therapeutics very difficult. However, postoperative ileus is not a yes or no occurrence. The recovery of postoperative GI function occurs along a spectrum, and in order to adequately describe the construct of GI recovery, an expert panel developed a new outcome measure called the IFEED classification scheme, which was developed at the second perioperative quality initiative. The IFEED classification scheme involves 5 elements: intake, feeling nauseated, emesis, physical exam, and duration of symptoms, each being scored 0, 1, or 3, depending on the severity. And this categorizes patients into the normal group, the postoperative gastrointestinal intolerance group, and the postoperative GI dysfunction group. Furthermore, each category is supplemented by a proposed management plan. However, this scheme has yet to be validated within a clinical or research context. Therefore, our objective was to provide validity evidence for the IFEED classification scheme to measure the construct of postoperative GI recovery in patients undergoing colorectal surgery. We did this by performing a secondary analysis on data from a previous randomized controlled trial that investigated fluid management strategies in patients undergoing elective colorectal surgery within an enhanced recovery pathway from 2013 to 2015. The enhanced recovery pathway at our institution involved starting patients immediately on PO intake after surgery, encouraging mobilization and early removal of IV lines, and discontinuing IV fluids as early as postoperative day 1. The primary outcome of the study was ileus. Therefore, many of the variables related to the IFEED were collected prospectively. However, few variables had to be collected by chart review, and these involved response to antiemetics in those patients with nausea and the amount and type of vomiting. The primary outcomes of our study involved the GI3 score, which was the interval time from surgery to tolerating a solid diet and passing the first stool or gas, complications within the initial postoperative period, and patient recovery, reported recovery, which was measured with the quality of recovery 9 score on both day 2 and day 4 postoperatively. So in order to provide evidence for the construct validity of the IFEED, we tested the 4 following hypotheses: that patients with POGD will be associated with a longer time to GI3, a longer length of stay, and more complications and lower recovery scores. So for our patient demographics, our cohort involved 128 patients. Mean age was 61, and as with a typical colorectal practice clinic, 71% of patients presented with a malignancy, of which 39% had a rectal pathology, and 99% of these patients underwent laparoscopic approach. With regards to our primary outcomes, the median time to GI3 was 1 day, the median length of stay was 4 days, and the overall complication rate was 30%. After we categorized the patients according to the IFEED score, so 48% of patients were within normal, 22% of patients developed POGI, and 30% of patients developed POGD. The IFEED scheme involved recommended management plans as well for each category, and our cohort demonstrated consistent values with the proposed management. You can see here that the patients that required NGT, TPN, or IV fluids of more than 1 day postoperatively were within the POGD group. And now regarding our hypotheses, looking at our construct validity hypotheses, we confirmed the first hypothesis in that patients in the POGD group had median time to GI3 of 2, which was significantly slower than the normal and POGI group. Then for our second hypothesis, patients within the POGD group demonstrated a length of stay of 7 days, which was significantly longer than the POGI and normal group at 3 days. Our third hypothesis demonstrated that patients in the POGD group had a 47% complication rate, which was significantly higher than the other two groups. And lastly, patient-reported recovery was significantly lower in the POGD group on both day 2 and day 4 postoperatively. So in summary, in the study, we confirmed the hypotheses that patients with POGD have been associated with a longer time to GI3, a longer length of stay, more complications, and lower recovery scores. And therefore, we provided preliminary validity evidence for the IFEED classification scheme to measure the construct of postoperative GI recovery. Thank you. Any questions?
Thank you.